we are talking about the walk-in uveitis patients. That's what happened. It's not moving. It's not moving. Okay. Intermediate uveitis and enigma. Let me start with the case. This patient did walk in and flew from Tanzania. 46-year-old male came to clinic with a dimness of vision. He was a known diabetic and hypertensive. He had already received 2 intravitreal injections of triamcinolone for cystoid macular edema, diagnosed as chronic uveitis. Vision was 6.5 in the right eye and 6.9 in the left eye. Right eye was quite left eye when there was a flare and cells in the vitreous. And then best-corrected visual acuity came on 13/12/2009, complained of blurred vision on the left eye. The patient had hemoglobin, glycosylated hemoglobin 11.6, and he had vitreous cells and vitreous age. And you can see the left side of the eye, left eye, has got vitreous cells almost 2+. And there was a cystoid macular edema. How do you treat a patient with 11.6 hemoglobin HbA1c? We cannot give oral steroid. So intermediate uveitis, spillover anterior uveitis with cystoid macular edema was the diagnosis. We give intravitreal Ozurdex and topical steroids in the left eye. And you can see that this patient has improved significantly and all the vitritis has disappeared. And the patient got back 6 and 6 vision. We are now talking about intermediate uveitis. Some of the salient points I will highlight. It's the inflammation that predominantly involves the anterior vitreous, peripheral retina, and pars plana of the ciliary body. Pars plana is that subset of intermediate uveitis in which snowball exudates in the vitreous and snowbank formation in the pars plana seen. There is no association of systemic disease in this case. Sun working group in 2021 divided the intermediate uveitis in 3 types: pars planatis type, non-pars planatis type, and associated with the multiple sclerosis. And this is the pars planatis type. You can see the snow banking associated usually idiopathic disease. And what they complain of, any patients of uveitis complaining of floaters, you should look for vitreous cells and exudates, painless blurring of vision. Dramatic vision loss can occur when there is a vitreous hemorrhage, CME, disc edema, which is rare. Pain can be there when associated secondary glaucoma. Anterior segment quiet eye, often this is a white eye uveitis. Band-shaped keratopathy in children in particular, mild anterior chamber reaction, Martin fat keratinic precipitates you can see in the sarcoid and TB, peripheral anterior synechia, posterior synechia, secondary glaucoma. Posterior segment you see vitreous cells, anterior vitreous cells. You should focus behind the lens and you will be seeing vitreous cells and strand, mild to moderate vitreous age, snowball opacity, snow banking, retinal vasculitis may not be very obvious, peripheral retinal neovascularization, particularly in the children. And here is, I took a photograph to demonstrate that vitreous strands and opacity. These are vitreous cells. CME and its sequelae, even macular hole can be there, retinal vasculitis, retinal detachment, disc edema. Natural course of this, don't tell the patients that will be cured because self-limited is the 10%. It's mostly a chronic or recurrent disease. 60% smoldering, 30% recurrent. And these are the diseases in our country: sarcoidosis and tuberculosis to be ruled out. Multiple sclerosis is relatively rare, and Lyme disease occurs in particular areas where Lyme is prevalent. We had a sarcoid intermediate uveitis series in Indian Journal of Ophthalmology 2022 when we have described 29 patients of sarcoid intermediate uveitis. Mean age was 42 years, bilateral majority, good results with oral steroid and immunosuppressive agents. Female were common more than the male. We also described 22 eyes of 14 cases of tubercular intermediate uveitis, which was PCR confirmed. And this is one of the examples, granulomatous uveitis with broad posterior synechia, and there was the vitreous exudates and cells, and these patients had undergone vitrectomy for the diagnostic reason, and then the vitreous aspirate on real-time PCR and nested PCR or positive for mycobacterium tuberculosis DNA. So muscular syndrome, toxocariasis, Ehlers disease, amyloidosis, they can mimic intermediate uveitis. These are toxocariasis, And this is the amyloidosis, which on optical vitrectomy showed congruent stain positivity with birefringence and polarizer applications. So we have primary non-familial amyloidosis of the vitreous, mimicking intermediate uveitis. Vitreoretinal lymphoma, this is the most important point in the elderly particularly, and can be in the young also, can mimic intermediate uveitis. Their vitreous cells, coarse cells, much larger, and they might have the posterior segment pathology like exudates, mass lesion like aurora borealiasis. How do you work about the patient? CBC, DLC, ESR is important. We should do, I don't do chest X-ray, I do the HSCT chest, Manto to rule out tuberculosis. Serum AC, though not the best marker for sarcoidosis, should be done. Quantiferon TB gold test. And what Sun group tells that all patients of intermediate uveitis, one need to rule out syphilis. Syphilis can mimic any type of uveitis. I just show you an example, 25-year-old female, blurring of visions and floaters. Look for the vitreous cells and debris, and we could see it. Is it due to TB? Yes, it was a TB, and it was found to be HSCT chest. When you did that one, you consider parenchymal infiltrate. And real-time PCR CTAP showed 2,204 copies of the MTB DNA. Intermediate uveitis can be due to sarcoidosis. Here you can see the bilateral hilar lymphadenopathy, and the intravitreal methotrexate also we have given in intermediate uveitis associated with multiple sclerosis, and it's a rare case of multiple sclerosis showing periventricular lesion of the cerebral white matter. And there's a vitreous exudasis seen. What are the ancillary tests? FFA, UVM, and OCT. OCT is quite important to rule out cystoid macular edema. This is a 12-year-old female where you did the FFA, and you can see the capillary farning, which can be seen in a lot of intermediate uveitis cases, particularly in the periphery. In addition, there was a hot disc suggestive of inflammation. And this patient was treated with immunosuppressive agents. When you do UVM in intermediate uveitis, when the pupil is small, cataract precluding the view of the peripheral fundus, and you can see the exudates over the pars plana showing by the arrow, and with the treatment it disappears. We can have the cystoid macular edema on fluorescent angiogram with increased macular thickness, and the guideline of the treatment is the intraocular inflammation, CME, cataract, vitreous opacity, retinal detachment, vitreous phase. Most of the cases are mild and respond to periocular steroid, and the posterior subtenon injection, first step, oral prednisolone, second step, immunosuppressive agents, third step, vitrectomy is in the final stage when it's recalcitrant. However, nowadays switch to immunosuppressive agents right away because due to the chronicity of the disease. These are triamcinolone acetonide given in the posterior subtenon space, and we can see that there's a video showing in the cotton bud applicator. If you apply of that on the supratemporal quadrant, there's a very little pain in the eye, and one can give the injections in the superior temporal quadrant. Bilateral cases oral steroid is required. Failed periocular injection, 1 milligram per kilogram per day, taper 10 milligram per week, or 5 milligram later on. Low dose of steroid if protracted course. Immunosuppressive agents in refractory cases, I choose mycophenolate mofetil 1 gram BD, and one can use azathioprine 50 milligram TDS. Cyclosporine is not that very effective. Dexamethasone intravitreal implant has come in case of particular macular edema and recalcitrant vitreous haze, and the implant is placed in the vitreous cavity. Is a biodegradable implant, sutureless, office-based procedure. Often you can do an OT also, and there can be, this is a case of cystoid macular edema. 6 times the patient developed cystoid macular edema, responded elegantly with intravitreal Ozurdex implant. So in our experience with the 20 eyes of the 50 patients was responded very well with the treatment, and that one found to be very safe and efficacious. So this is Ozurdex implant, and it's getting degraded. Vitreoretinal surgery is intractable vitreous inflammation, vitreous opacity, membrane unresolved vitreous hemorrhage, retinal detachment, and sometimes in persistent cystoid macular edema. Cataract is another complication. Vitrectomy found to be effective when there is a recalcitrant uveitis. This is one of the cases where there is a dense vitreous opacity with exudates, and here vitrectomy will work out well. Complicated cataract can occur in that patient 7.8% 1 year, increasing to 36.6% 10 years. When do you operate? Wait at least for 3 to 6 months, best for the burnt out stage, preoperative topical, systemic and periocular steroid, IOL in the capsular bag, foldable eyelid. In case of hypertony, you may need to combine with the pacemaker vitrectomy. So in summary, the quite common type of uveitis is the intermediate uveitis. 1 in 5 of uveitis cases is intermediate uveitis. Rule out TB and sarcoid. In the elderly, keep with primary intraocular lymphoma in mind. Individualize the treatment, and prognosis is relatively good. I'd like to dedicate this talk to my mentor, Professor S.S. Badrinath, for this. Thank you. Posterior uveitis. Jyotirmay Biswas. So we'll take up the questions at the end. Second presentation. Yeah. Yeah. PGI group of the people has had a lot of studies to establish that new entity, subretinal abscess, choroidal nodule. 17-year-old girl, this patient, biopsy-proven abdominal TB, presented with the first-aid meningitis due to abdominal tuberculosis. And look at the treatment. And if you give that effect of treatment, you can see that there is a complete resolution of the lesion. This is often a one-time disease, and you can cause or have successful resolution of the disease by appropriate treatment. So diagnosis is very important. So how do you diagnose ocular signs predictive of tubercular uveitis? This is a landmark article by Professor Ahmed Gupta, which is American Journal of Ophthalmology, which showed broad-based posterior synechiae, retinal vasculitis with or without choroiditis, serpiginous-like choroiditis is tubercular uveitis type. Which lab test you will do? Mantoux and quantiferon TB gold test is supportive only. Phenotype is quite important. Exposure doesn't mean active infection. Do anterior chamber tab, vitreous aspiration, FNAB when everything is negative or you are in doubt. Subject to polymerase chain reaction for MTB genome. And I like to look at this slide. There is a 40% of the positive cases were Mantoux negative. In a AFIP study, proven tuberculosis was found to be 40% Mantoux negative. So don't depend on the Mantoux negative. Another landmark article by Shomava Basu, which showed that tubercular serpiginous-like choroiditis can occur in patients with negative tumor TB immunoreactivity test. So don't keep an age-old view that you have to get Mantoux positive to have the tuberculosis. Utility of the quantiferon TB gold test in South Indian population, which we found that the combination of positive PPD test, quantiferon TB gold test, in addition to clinical presentation may be more useful. X-ray test is not enough. 40% of the tuberculosis will be missed by X-ray test. Do a high-resolution CT test. We did a study of role of high-resolution computerized tomography of the chest, and with 81% TB, 8.3% sarcoidosis was detected. And the subretinal abscess of this case is showing example of tree in the bud appearance of HSCT chest. When is the doubt, what is the role of intraocular fluid sample? You can do the PCR. Sensitivity is around 80%, specificity 100%. And here is an example of agarosal electrophotogram showing MPB64 and IC1310 region positive. And this is a subretinal abscess FNAB specimen of the PCR, small tiny specimen, 0.1 ml, showed the Mycobacterium tuberculosis DNA. How to treat tubercular uveitis? Start with the 4-drug antitubercular therapy, always combined with the steroid at the beginning itself. I give levofloxacin instead of ethambutol to prevent the toxicity. What is the correct duration of antitubercular treatment? Some of the salient points I like to highlight. treat as a neurotuberculosis and treat at least for 9 months. And what happened to this patient with the subretinal abscess? You can see appropriate treatment. There is a complete resolution of the lesion with improvement of the vision. Next comes toxoplasmosis, which was earlier the most common posterior uveitis. Is caused by the toxoplasma, and this is a congenital toxoplasmosis where nothing much you can do, and the active toxoplasmic retinochoroiditis is typical satellite lesion or headlight in the fog appearance. This atypical toxoplasma can be challenging in the diagnosis, particularly when they present with the exudative detachment or in an HIV-positive patient with diffuse multifocal de novo foci. It was treated as an viral retinitis. When it did a PCR, we found PCR of the vitreous was positive for toxoplasma. After treating with the intravitreal injection, all the retinal lesions are gone. Ocular toxoplasmosis is a clinical diagnosis. ELISA to confirm. You can start the treatment even before getting the ELISA result. PCR of the intraocular fluid in atypical cases. Now come to the next treponema, which is now emerging as a new disease. And this is 43-year-old male, dimness of vision and floaters, diagnosed as CMV retinitis, HIV positive, treated with the intravenous ganciclovir even. I shake hands with all patients routinely, particularly adults, and I found something wrong in his hands. And what else we found? You can find the scaly lesions in the hands, and this was a syphilis. When you look at the fundus, we can see the subinternal limiting membrane deposits, ground glass appearance. It was RPR TPHA positive and treated with injection venlafaxine in and look at the picture, whole thing disappears and complete resolution. As I told, this is a one-time disease also. It's so gratifying to give that anti-syphilitic treatment and get the vision back. Although it was an accidental finding, our mind has to be prepared. When do you suspect syphilitic uveitis? In any uveitis, particularly atypical type, serological test, we do both VDRL to see the state of activity, FT-AVS, high degree of sensitivity and specificity. So coming to that treponema after that, viral retinitis, which is a real emergency in uveitis. This is a 30-year-old female immunocompetent 10, and this patient had got necrotizing retinitis in the posterior pole only. And look at the patient. If the room light is on, you could see on the forehead vesicles were there, and this patient has got varicella-zoster retinitis, and simple treatment with the intravenous acyclovir causes the resolution of the lesion with improvement of the vision. Viral retinitis can have myriads of active protein manifestations, but this is a case of acute retinal necrosis. The patient is still in the ward. Now he was caused by the VZV virus infection and is a peripheral lesion. PORN is another type of retinal necrosis. It starts from the center to the periphery. Vessels are not involved. And this is CMV retinitis, classic Pizza-Pie appearance with vasculitis 1. When CD4 count less than 50 cells, they are fulminant form, indolent and granular type, exudative pattern. Cells more than 50 cells per cubic millimeter CD4 cell count, they can have slowly progressive granular retinitis, pan-retinal occlusive vasculitis, significant intraocular inflammation. Viral retinitis is one of the conditions where PCR is indicated to find out what type of virus. I don't want to go into the details of the treatment. ARN is treated with intravenous acyclovir, with intravitreal ganciclovir, and PORN is treated with intravenous acyclovir and intravitreal ganciclovir. And CMV is intravitreal ganciclovir or followed by the oral valganciclovir. Last is the post-fever retinitis, which you are seeing in Indian subcontinent quite commonly. Could be dengue, chikungunya, typhoid, rickettsia, and Epstein-Barr virus. So we complete the TB, and the TB is showing that the often proteus manifestation to treat the infection primarily, systemic steroids to control the inflammatory component, supportive anti-inflammatory therapy only. So periocular intravitreal steroids, strictly contraindicated, intraocular fluid evaluation when in doubt. Thank you very much. So we go to the next one is the structure-wise comes the pan-uveitis, and it will be given, the talk would be given by Dr. Binita Girish Rao, who is my colleague in Shankar Netralaya, who has got enough experience in VK, sympathetic ophthalmia, etc.
Thank you, sir.